Hello and welcome to today's webinar. My name is Brianna Gregory, pharmacist and physician liaison with Physicians Preference Pharmacy. And I want to thank you so much for joining me. I love doing these webinars and having the opportunity to share with you some of my favorite information about the prescriptions that we offer at Physicians Preference Pharmacy. And especially today, I'm actually going to be sharing some case studies towards the end of this presentation, and I don't think that anything speaks louder than personal success. So I'm very excited to share those with you. So I'm going to go ahead and share my screen. I have a PowerPoint, of course, that is going to be jam-packed full of information as usual, but you will be getting the recording of this. So you'll also have access to the slides. I do like to jam pack my PowerPoints with information so that you can go back, you can refer to it, you can see kind of the technical information behind it. So you're more than welcome to just sit back and relax and take it in, or certainly take notes if you wish. So today we are coming together to discuss two different prescription medications. And usually, although I present either on a chronic type disease or a diagnosis or just one drug, there are a few reasons why I'm going to be discussing two. So in pharmacy, oftentimes we will discuss synergy or synergistic activity, which means that two products work better together than on their own. That part is still being investigated between these two particular prescription medications. However, we are consistently learning and we're getting patient feedback, and we believe that there probably is some synergy that happens here. So like I've discussed before, I often do focus on repurposed drugs. Both of these drugs fall into that bucket in the repurposed drug category. So they're nothing new, but they are on our formulary, and LDN's been on there a long time. Amlexanox has been on there a couple years. So it is the newer kid on the block, but it's still been around a while. So I always like to start out with a little bit about our pharmacy. So there may be a blend of people on this webinar. Sometimes it is people that have been using our pharmacy for a long time. And sometimes these links have been forwarded to people that can benefit from the information. So whether or not you're a seasoned guest of ours or brand new, I want to welcome you here and tell you a little bit about our pharmacy. So at Physicians Preference Pharmacy, we are a compounding pharmacy, compounding only. We are non-sterile, which means that we do not compound or make any injectables, any IVs, or anything that goes in the eyeballs. We do specialize in BHRT, which is bioidentical hormone replacement therapy. So that's your sex hormones, your adrenal hormones for the most part, also peptide therapy and some immune modulating compounds. We are going to be talking about two drugs this evening that do balance out the immune system. So that's where we'll be focusing. All of our prescriptions, no matter what it is that you're getting filled, are always going to be free of any unnecessary dyes, binders, fillers, artificial sweeteners, lactose, parabens, which are hormone disruptors. Basically, like I always say, just free of all the junk that you simply don't need in there. We just want the basic ingredients that you need to feel your best. The dosage forms that we offer and that we'll be discussing this evening include oral capsules, also creams, but in addition to the ones that we'll be talking about tonight for Amlexanox and LDN, we also offer oral suspensions, sublingual tablets that dissolve underneath the tongue, as well as nasal sprays. We do ship directly into 49 states, and that currently excludes Alabama. All patient prescriptions must be specific to that patient. So we don't ever compound for office use and send directly to the office. We want to be sure that we maintain a relationship with each and every one of our patients. We also believe that it is important to take a root cause approach, and that oftentimes prescription drugs are overprescribed, really missing the mark and creating more of a band-aid approach than a root cause approach. But instead, we're trying to get to the root cause of what's going on and potentially causing your symptoms. We are PCAB accredited, which means that we strive for voluntary accreditation by the Pharmacy Compounding Accreditation Board. So this is something that we voluntarily seek out, that even though we are required to report to the state boards of pharmacy, and that's who technically regulates us, so 49 different state boards of pharmacy, we take it upon ourselves to go above and beyond that to test our products on site, also through a third party, and have more stringent rules and regulations and standard operating procedures behind our closed doors. All right. So first up is Amlexanox, absolutely one of my personal favorites. And this is a compounded drug that primarily focuses on inflammation and metabolic disease. So those are two huge areas of focus, not just because they're really relevant right now, but also when we say inflammation, what does that mean? It's a very broad term, as is metabolic disease. So what is Amlexanox? Like I said, it is considered a repurposed drug. So it was previously available as an FDA-approved drug and branded as something called Apthosol, and it was an oral paste. So it would go inside the mouth and it would cover ulcers to help heal those ulcers. Now, we know that whenever ulcers show up, particularly in the mouth, it is a sign of immunosuppression or a weakened immune system. So when a patient would put Apthosol or Amlexanox on that aphthous ulcer, it would heal it, which means it was regulating the immune system function within the mouth. Now, Amlexanox is no longer available as a commercially available manufactured drug. It fell out of favor several years ago, but like with a lot of things, there can be some fluctuation like that on the drug market. And what happens from country to country or continent to continent can be very different, as you very well know. So Amlexanox is still widely being used very successfully in other places, but especially Japan, to treat conditions like asthma, allergic rhinitis, and conjunctivitis. It also shares structural similarity with drugs that we're familiar with, like cromolyn, nasal crom, gastrocrom. Those are all forms of cromolyn sodium that we use to balance out the immune system and address things like allergic symptoms. So it shares these structural similarities, meaning that chemically the structure of it looks the same, but it provides antihistaminic mast cell stabilization, which means what? So it works as an antihistamine. So keep that in the back of your mind because we're going to talk about histamine, and also helps to stabilize the mast cells. I talk a lot about mast cells. If you had not heard me talk about mast cells before, we talk about how mast cells are a type of immune cell. They are a white blood cell, and they are really responsible for keeping you alive. The thing that is really unique about mast cells is that they're present in nearly every single system of the body. So what I mean by that is the cardiovascular system, the lymphatic system, the central nervous system, the GI system. And so because of that, when people have dysregulation of those mast cells, those immune cells that live in all these different areas of the body, they present with some really wild symptoms. Why? Because those cells are present everywhere, they start having symptoms everywhere. Unfortunately, these are usually the people that go to the doctor and the doctor says, listen, either I don't know what to do with you, I can't help you, or it's all in your head. Because a lot of times these people show up looking physically fine. Even their labs may show up to be perfect, but they couldn't feel worse. My mast cell overactivated patients are my sickest patients, hands down. So something to keep in mind about Amlexanox is, again, it works like an antihistamine drug in many ways, and it also helps to balance out the function of the mast cells, sending a signal to the brain and the body saying, hey, it's okay. You can keep on high alert to be sure that we're not experiencing anything offensive or traumatic, but you don't need to overactivate, because it's that overactivated immune system that causes a lot of problems. So Amlexanox is a novel anti-allergic and anti-inflammatory drug. Amlexanox has recently been found, though, to have a much broader list of applications, ranging from metabolic disease and mast cell stabilization to balancing out the immune system and even correcting gene expression. So who is a good candidate? You might be wondering, am I? Is someone that I know maybe a good candidate for Amlexanox? Well, those people that have chronic inflammatory conditions, autoimmune conditions, mast cell overactivation, for short, we call that MCAS, mast cell activation syndrome, or metabolic dysregulation. Metabolic disease, metabolic dysregulation, that is considered a diagnosis. Usually, when you think of that, you think of the obese individual, but that's not the only thing. There are some other cardiovascular issues and literal metabolic issues. How fast is your metabolism running? In addition to blood sugars, weight gain, and all of that, that gives a physician the presentation and kind of the checklist of this person has metabolic dysfunction. We all know that, especially in the United States, we are the most metabolically dysregulated country, and it's very sad. You look at pictures from many decades ago, this was not an issue. So we clearly have drug issues. We have, meaning that we have the overprescribing of drugs that are leading to this. We have patient access issues to drugs, which are leading to this. And we also have a major food pyramid issue. By the way, if you've seen the links that I put in the chat, there is something I want to address at the very end of this webinar. It's something I need your help with. It's something that requires a major call to action, but it also plays into metabolic dysregulation. So if you're wondering why those are in there and they don't touch on the topic of these two drugs, I will explain that. When we think of treatment refractory, what that means is I've tried everything and nothing works, or I've tried a lot of different things, but they've never really given me full resolution of my said symptom. So whether that's chronic or you've tried everything, it's just not working. A lot of times we see this be an issue with skin conditions. So eczema, psoriasis, where there's been an overreaction within the body that is manifesting on the skin. So the root cause is not coming from the skin usually. It's usually coming from the inside out. Also, Amlexanox can be a good choice for those people that desire weight loss. It's not a GLP-1 drug, it's not Ozempic, it's not tirzepatide, and it's not classified as a weight loss drug. But there are many mechanisms of action of Amlexanox, meaning there's a lot of different ways that it works to address different issues within the body, which is why it's so impressive, and a lot of people consider it to be kind of a magic bullet. But remember, it's working on the mast cells, and the mast cells live everywhere. That's why it can help conditions everywhere in the body. That being said, the way that it can affect weight loss or support weight maintenance is one of the most intriguing things about this drug to me, which I'm going to talk about. So whenever we think about Amlexanox, think about conditions largely related to T helper cell dysfunction. T helper cells are just a part of the immune system. However, when we see dysregulation, a lot of times that's when we see autoimmunity, the body turning back on itself, causing a reaction, or skincare conditions, which is a classic presentation of T helper cell dysfunction. All right, I talked about metabolic dysfunction and how the weight loss or weight maintenance portion is one of the most interesting parts about this drug to me. So like with most drugs, there is a rigorous drug approval process that drugs have to go through before they ever make it to market, and many of them do not make it to market. So usually, well, we have safety studies, we have efficacy studies, and then we start moving in towards human studies and longevity studies so that we can continue to gain information, not just about how these drugs work, but also to help us refine dosing so that by the time we can compound it in our compounding lab or it's a commercially available drug that's released to the public, we know that the dosing is going to be spot on. So I say over here that the dosing in this particular study was an open label trial to ensure safety. So that was the purpose of this study. The dosing here was 25 milligrams 3 times a day of Amlexanox, and we're dealing with metabolic dysfunction. So again, obesity, glucose dysregulation, and this particular study looked at how taking Amlexanox 3 times a day was affecting metabolic dysregulation. And what they found is there was a measurable reduction in fasting blood glucose. So when you go into the doctor or you go into the lab and you get your blood drawn, usually depending on the lab you're having drawn, you will have to go in fasting. And part of what they're collecting there is information about fasting blood glucose. So what we're looking at are we are looking at the body's ability to manage glucose in a fasted state when you have not eaten, usually for 8 or more hours, or what happens with your blood sugar regulation after you have eaten a meal, because those are two different data points that are very important. So they saw that there was a measurable reduction in fasting blood glucose and fasting insulin, and that insulin resistance was improved for patients, which in this case had type 2 diabetes, and they also had non-alcoholic fatty liver disease. So whenever you go into the doctor, when you get those labs done, oftentimes what they're looking for are several data points that say, hey, this person is trending towards type 2 diabetes, or oh my gosh, they're already meeting the requirements to be diagnosed with type 2 diabetes. So what a lot of what that is it's a 3-month average looking at blood glucose and how glucose sits on the cells. And so it's easy for us to catch early if we do that lab work routinely. But Amlexanox can help to improve all of those metabolic markers. We also see here that they observed decreased hepatic glucose production. Hepatic is liver. So we want to know too, how is the liver releasing that glucose into the body when it's needed? Is it too much or is it too little? Following that open label trial, you can see here that they then bumped up this dose to twice what it was before, 50 milligrams by mouth 3 times a day for proof of concept. So they proved it was safe, but now what? How do we refine the dosing and be sure that we can actually get a clinical evaluated response from patients? So what they found is that there was definitely an inflammatory link. So inflammatory between someone being obese and having type 2 diabetes. Usually we think of someone who has type 2 definitely being obese. Well, we don't always think about the inflammatory component. So earlier when I said it's so interesting to me how Amlexanox works here is that if the weight gain or the visceral fat gain, which is usually around the midsection, kind of where we get that extra tire, if that is inflammatory driven, when someone takes Amlexanox, it's expected to help reduce the inflammation, which then helps to kick something called lipolysis into gear, which is just a fancy way of saying fat breakdown. So as it addresses the inflammation, it helps with normal fat breakdown. People break down fat and then they lose the fat and they lose the weight. So they saw here in this study reduction of weight, reduction of insulin resistance, and fatty liver and inflammation. Also, this was a double-blind placebo-controlled study of 42 obese patients with that type 2 diabetes, again, and non-alcoholic fatty liver disease. So fatty liver and non-fatty liver can happen obviously for different reasons. One creates a fatty liver, one does not, but it creates a dysregulation in metabolism. There are many things that get stored, including nutrients, and glucose in its appropriate form gets stored in the liver. And then when we need it, the liver goes, okay, I know, and I'm going to release it now, and I'm going to send it out into the body. That's part of metabolism. But if that goes rogue, then so do our lab markers, our metabolism, our weight, etc. Okay, so if you're a table person, a bullet point person like me, then I have created a table here for you so that you can see a real quick snapshot of the benefits and uses of compounded Amlexanox. So first we look here on the indications on the left-hand side, and then also the mechanisms of action, which is just a fancy way of saying how does it work. So I already talked about how it is a mast cell stabilizer, and it does this by reducing the release of histamine primarily and leukotriene mediators, which is just a part of inflammation in the mast cells, as well as neutrophils and monocytes. So those are all really important cells and really chemical mediators or communicators as part of the immune system or the process of inflammation occurring. So again, when we talk about the mast cell, it's present everywhere, but something to keep in mind about the mast cell is it's very interactive. So it has about 300 different types of receptors on it, meaning that it may have one receptor for hormones, for example, another receptor for histamine, and all kinds of different things. And so that being said, it's very interactive with its environment, making it on high alert at all times. When something binds to the mast cell, it's a bit like a lock and key. it turns on or activates the mast cell, and the mast cell starts spraying its contents like a skunk, and it does it in a very uncontrolled manner. The reason it does this is because, again, it's just trying to keep you alive. It's trying to say, hey, hello, there's something in your environment that is very harmful or traumatic or offensive, and you need to get out of here. An example of that might be eating a high histamine food or having too much of a certain hormone or a lack of a certain hormone. So hormone imbalance. Also, the most classic example I can give you is somebody with allergies. Think about environmental allergies like pollen, for example. You're sneezing, you may have hives, you may have a rash. That is all a product of the mast cells going wild, spraying histamine and all of their contents. Amlexanox can help with that. Also in cancer. So a lot of what we look at, like I said before, we look at the balance of the T helper cells. Amlexanox inhibits something called the Th17 cell without inhibiting a Th1 cell. All about balance. This really has a role in cancer and can be a part of cancer treatment regimen as well. Longevity and inflammation. So Amlexanox promotes something called cellular autophagy, which is your body's and your cells' natural ability to detoxify. It does this by working on a pathway called the mTOR pathway and induces apoptosis, which is the killing off of weak cells and toxic cells. So that's how it produces longevity or supports longevity, is by decreasing inflammation. Whenever we promote cellular detox, think about how bad you feel if you just feel toxic, or maybe you're constipated, you haven't gone to the bathroom, you haven't been moving, you haven't been sweating, peeing, pooping, all these things that allow us to detox well, you just feel junky inside. Well, if you feel like that, that is the sum of many of your cells experiencing that as well. So when we can ramp up cellular autophagy or detox, of course, we're going to live longer. We're not going to be exposed to those toxins. It also balances out the immune system. We talked about this already. Neurodegeneration. So when we talk about the central nervous system and how that can break down sometimes, it can help to decrease inflammation and toxic stress, which is oxidative stress, which causes that breakdown. So it can help to intervene there. Also with erectile dysfunction. So interestingly, Amlexanox promotes maintenance of an erection due to PDE5 inhibition. That's phosphodiesterase 5 and inhibiting that. So when you look at a lot of your ED drugs that are available on the market, their mechanism of action is inhibiting PDE5. It just happens that Amlexanox also inhibits PDE5. So that's where that overlap is. And then oftentimes we'll use it as an antifibrotic as well. So it binds to fibroblast growth factor 1, which can be useful in atherosclerosis, which is a type of fibrosis, also liver cirrhosis, and non-alcoholic fatty liver disease. Okay, so I talked about the weight gain or the reduction in inflammation around the midsection. This is all just a description of that here. If we can stimulate that process and fat breakdown, then we will have weight loss as well. And Amlexanox can also open up the vessels. And for this reason, it helps to reduce blood pressure and improve circulation for many people because it's working on the walls of the vessels to address that. We talked about non-alcoholic fatty liver disease already, and then psoriasis. And again, when we look at different skin conditions, whether that's eczema, psoriasis, rashes, we get a certain balance of activity of the Th1 cells and the Th2. Depending on whichever one is overactivated at that time, that's when we see certain symptoms versus a different condition. So really, take home point, we just want it to be balanced. There may also be an application in genetics. So there have been some studies done that show that Amlexanox may correct gene expression in cystic fibrosis. If there's one thing you may know about cystic fibrosis is it is a genetic related issue, but what happens there is it causes the chloride channels in the skin to misfunction. So there's major salt dysregulation, etc., and Amlexanox may have a place in that. Probably two of the most common categories that we use it for are these last two: asthma, allergies, and bronchodilation. This is why I take Amlexanox. I have said before, I am a California transplant to Texas. And when I first moved here, many people say, and it's just kind of a joke, especially around the Houston area, but in other parts of Texas too, when you move here, you'll get allergies. And I've lived in several different farming towns throughout my life, and I've never had any issues with bronchospasms or allergic reactions or anything like that. But I do experience that in Houston. So I have a significant amount of things on board to address the different reasons why that's happening, including addressing food, environmental, and chemical sensitivities, all three of those areas. That being said, part of what I deal with is the spasming of the respiratory tissue, and that can happen because the mast cells get overactivated. Again, they're just trying to keep me alive and tell me, hey, get out of the Houston smog, or be careful with the oak pollen that's coming in, or pine pollen that's coming in from Austin, or something like that. Apparently, we've also got the Saharan dust issue, so that's a whole separate conversation. But Amlexanox inhibits that PDE, remember that PDE5 we talked about for erectile dysfunction, but phosphodiesterase and something called CAMP, which can lead to opening up the airways in the lungs, reducing inflammation, and decreasing allergic responses because of that histamine release. So if you think about antihistamine drugs, such as Benadryl is probably the most common example. Why do you take that? You take that because you got a bee sting, or because you had an environmental allergy, or you had a rash. Well, what's the problem with that other than it being uncomfortable? You don't want to have a sustained rash or a closed up airway. And so what you do is you take an antihistamine, and what it does is it calms the histamine response. And that's also what Amlexanox is doing. However, with Amlexanox, unlike antihistamines and steroids, we don't get the same side effects. And that is a beautiful, beautiful thing. Also, what about our long haulers? So we are 5 years post-COVID, and we still have a lot of patients that come to us because they obviously do not have the COVID infection that they got 5 years ago, but they are having sustained symptoms. So we refer to that as long haul COVID syndrome, long hauling, long haulers, long haul COVID. But there's a big overlap between that and mast cell overactivity. One of the most common symptoms that people have when they have those sustained issues from a past COVID infection is the brain fog. So they have trouble with word recall. They feel like their head is physically swollen. I've heard a lot of people say that they feel like their brain is too big for their head. So it's obviously a lot of inflammation that's happening there. But also, if you have continual inflammation in the brain, it's not going to be functioning right. And so that's kind of what we refer to as brain fogginess. The reason that that brain fog is sustained is because the mast cells have not been turned off. So remember, the mast cells turn on or activate when they perceive an issue, which means they're continually perceiving an issue. So we can use Amlexanox to help wind down and calm down the function of the mast cells so that it's sending a signal to the body saying, hey, all right, it's fine. You can stop overreacting. And then when you do that, then I can focus on healing. All right. So what about some clinical pearls? This is how I would explain it or present it to physicians. And so our available doses that we use for Amlexanox, so some of the take-home points here or key points on dosing, is that we actually have 4 different doses available on our formulary, meaning the list of things that we make. I really tell docs, don't even really mess around with these bookend doses. I always recommend going for the 40 milligrams. The reason why is that's the sweet spot. If you remember on the 2 studies that we looked at, they studied 25 and 50, so we're well within range there. But it also gives us some flexibility on dosing. I'll use myself as an example. I take 40 milligrams of Amlexanox every day for probably 350 days out of the year. The other 15 or so, I probably take 1 capsule twice a day or 1 capsule 3 times daily. Last week, we had a pretty big storm that came through, and just like always happens, it's bringing in a bunch of junk in the air, and it's causing those allergic reactions to be amplified or allergic symptoms to be amplified. For me, again, I get that spasming of the respiratory tissue. So for me, I rely a little bit more on higher doses of Amlexanox during that time. And I tell physicians, I say, when you prescribe this to your patients, give them a little bit of liberty to bump up on the days that they need it, not to be taking or relying on it 3 or 4 times a day around the clock, but when they need it. And I think that that can be very helpful. Most people, let's say 90%-ish people, patients that I have, do great on 40 milligrams daily. The more sensitive individuals that have really bad mast cell overactivation or autoimmunity will probably rely on 2 capsules a day, and that's split up into twice daily dosing. The long haulers that are real bad off are probably going to need it up to 3 or 4 times per day. There's really just one side effect that I warn with on Amlexanox, and that is mild queasiness. If you take it with a light snack or a meal, you'll be fine. For me, I routinely fast, which means that you can put usually a little bit of milk or half and half or something. You're putting a little bit of something in your coffee if it's not just black, not enough to break your fast. That is enough to coat my stomach, and I wait until I have had that full cup of coffee in the morning with the little bit of dairy in it to take my Amlexanox. Taking it on an empty stomach can cause queasiness, and we do not want that. So we always think about who are the treatment refractory people? Who are those people that have tried everything and it's just not working? Those people are really good candidates for Amlexanox. And one other thing I will say is that these people that usually are good candidates for Amlexanox are generally the most sensitive. So if you are listening to this or you know someone who sounds like this, then you should probably share this information with them about Amlexanox. But they might be the MCAS people, the people that have really overactivated mast cells. And so because of that, for one, it does not happen overnight, but what most of these people are dealing with on a daily basis is many of them cannot leave their house because they are so sensitive to the environment. They get sick very easily. They usually have a limited food list of about 10 or 15 foods. I know many people that have a food list that they can tolerate that's only 5 foods long. Anything, any type of exercise, any type of detox that they try to do is going to lay them up in bed for 2 to 3 days. And I have heard people explain it like this, but my best way to explain it is they have PTSD around medications, supplements, and foods, because usually one or all three of those categories have landed them in the hospital multiple times. Because what's happening at an underlying level is those mast cells, again, are saying, hey, whoa, whatever you are exposing me to, you got to stop. And so it's going to act up. It's going to rear its ugly head, and it's going to land that person in the hospital. So people are generally very apprehensive to try something like Amlexanox because usually they've never heard of it. But also they are scared to take medications because they do not react well usually. So usually it requires a lot of explaining of the why, the how it works, what it can help with. With mast cell overactivation, we have to stop the bleeding. It is a downward spiral for folks until we put some sort of wrench in the gears to stop it from that downward spiral. And so this is very helpful to help people introduce foods back into their dietary regimen so that we're not leaning towards malnutrition, but also allows them to tolerate their environment better so that they can get on a path to healing. All right, let's roll right into low dose naltrexone. It's way too long of a name, so we're just going to call it LDN. And we're going to address primarily autoimmunity, so autoimmune conditions where the body turns around and attacks itself, and inflammation. So, a conversation that I have probably not daily, but at least weekly, but I've had it multiple times recently, this week at least, is, oh my gosh, my doctor wrote me a prescription for naltrexone and I Googled it and then I saw it's for people that have been addicted to alcohol and opioids. I don't think this is the right prescription and you guys sent it to me and I don't think it's the right thing, and people get very worried about this. So I just want to debunk this right now. Is as a pharmacist, I am also a pharmacologist. So what we study and what we specialize in is pharmacology, and that is simply the study of pharmaceutical drugs and chemical structures. So that's this guy right here. So when we look at this, this is naltrexone. So naltrexone is a commercially available drug like this that comes in a bottle and gets sent to your Costco, your HEB, your Kroger, and dispensed as manufactured pills. What we're talking about is naltrexone, but low dose naltrexone. So it looks exactly like this. It is pharmacologically identical, but it is repurposed because it's a repurposed drug for a different use. Naltrexone is not the only medication that is used at lower doses or dosed at a lesser frequency, so less often, to get a different result. Perfect example of this, if you're listening, you may already be on this, especially if you get your medications from physician's preference, is rapamycin or sirolimus, as it's called. It is used to help people not reject an organ that has just been given to them. So usually a kidney transplant. They're given that for life so that they do not reject the organ and die. But that is given at a very high dose on a daily basis, where we dose it much, much lower and once a week. So you see that there's a major difference here, and that's what I want to delineate for you. So even though a high dose may be used for one thing, it is a completely irrelevant conversation with what we are dosing it for. So naltrexone is used to help people wean off of alcohol and opioids when they are dependent on that. It is not compounded. It is a commercially available drug, generally available or dispensed as a 50 milligram tablet. And people might take up to 300 milligrams a day. So I just want to be clear, that is up to 60 times the dose of what we're going to be talking about when we use it for autoimmunity and inflammation. So what about LDN? It's only available as a compounded product. It's considered to be anything less than 25 milligrams. And it's applicable again for inflammatory and autoimmune issues. So it is not used for the same things as naltrexone. Again, pharmacologically identical. Okay. So when we see where drugs bind, we learn more about how they work and what systems they're going to affect. So when we think about LDN, we should think it's all in the receptors. The answer is in the receptors. In 2003, there was an issue in the New England Journal of Medicine that provided evidence showing that opioids, so if you're talking about some of your opioid drugs like hydrocodone or something like that, they alter the development and differentiation and function of immune cells. So usually we use that for pain, right? And again, that points to some of the uses for low dose naltrexone as well, but it addresses different types of the immune systems, suggesting opioid induced immune modulation. And that actually can be helpful information. In addition to bone marrow cells, macrophages, which are part of the immune system, natural killer cells, which are very important in cancer, immature thymocytes and T cells, so a lot of fancy stuff on here, B cells, all different types of immune cells essentially. But the identification of opioid-related receptors on the immune cells, so meaning that opioid drugs can bind to immune cells, makes it even more likely that opioids have a direct effect on the immune system. So why am I talking to you about opioid drugs that are highly addictive and we don't even dispense at physician's preference pharmacy? Remember, it's all in the receptors. We're talking about what happens when said drug binds to said receptor and what happens. We know that the immune system is affected. So I'm going to shift. We're not talking about opioids anymore. We're talking about opioid receptors. So we actually have opioids in our own body that we make. They're called endogenous opioids, which means that we just make them inside. There's endogenous and exogenous. Those are endogenous. And those are referred to as enkephalins, which regulate pain, much like an opioid drug does, right? And endorphins, which is that feel good, like after you work out, you go to the gym, you're like, I'm feeling good about myself, my mood is elevated. Those are endorphins that are getting released. So again, it's all about the receptor. So these have similar chemical structures to LDN, and the receptors are found in the brain, the spinal cord, the stomach, the small intestines, and in the immune system, which means that not only do opioids work there, like our own opioids that we make, but also low dose naltrexone, which is why it can be used for chronic issues of the brain, of the spinal cord, of the stomach, of the small intestines, and of the immune system. That is so cool. So increased levels and activity of endorphins regulate immune cell production. Why do you think that people that work out regularly are healthier? This is probably part of the whole reason, not just because of the activity itself. It helps protect the immune system. So LDN works by increasing the body's release of endorphins into the immune system, that feel-good hormone, and this can decrease the immune system's inflammatory response on its own healthy tissues. LDN can decrease the immune system's response with inflammation on its own healthy tissues. What is that? That is autoimmunity. So it will help with autoimmunity. Common applications. Every year, I've been following LDN for a long time, compounding it for a long time, and the list just keeps getting longer of its applications. So I think it's over 100 different uses right now. These are our top ones in our practice. We have a lot of autoimmune thyroiditis patients, which is Hashimoto's. We see a lot more Lyme, celiac, which is the autoimmune version of gluten allergy or intolerance, Crohn's, ulcerative colitis, eczema and psoriasis I mentioned, and pain are probably the biggest ones. So again, if you're a table person, here's how it works. It helps to enhance immune function, inflammation, also can help in the stomach, and then regulating the immune cells as well. I do want to point this out because cancer diagnoses, that rate is increasing. And this is an excerpt from an article published by the Independent Medical Alliance, formerly known as FLCCC, which is the Frontline COVID Critical Care Alliance. So this is Paul Merrick, Pierre Corey, these people that were on the front lines. A lot of them were considered those frontline doctors that made a big push for ivermectin. And so there's been some fantastic research. If you know someone or if you need to have information for a cancer diagnosis, treatment, and guidance on what types of supplements and what types of drugs can again be repurposed for the use of bringing it in on a cancer treatment regimen, you got to check out this article. Again, if you go to imahealth.org, so I like igloo, Mary Apple, imahealth.org, it's called Cancer Care, or you can just Google IMA Cancer Care and you'll find it. It's a very long document, but partway down through that, it tells us how do each of these repurposed drugs or supplements work in an anti-cancer fashion. And what we're looking at across the top here is how does it help with cellular detoxification, killing off the bad guys, increasing immunity, decreasing the activity of the tumor microenvironment. And so what we're really looking at here that I've highlighted is low dose naltrexone. So it's got pluses almost all the way across. It does not affect the decrease in glucose or glutamine as it refers to the tumor functionality or what the tumor is doing. But we do know that it has an implication in many of these other areas. And cancer is a functionality of some sort of dysregulation in the body for whatever reason that it may be. And so since low-dose naltrexone brings us back into balance in many ways, that is how it can have a place in therapy. Here is just a quick snapshot of some formulations that we offer at Physician's Preference Pharmacy. So the easiest as far as compliance and low cost formulation that we have is the oral capsule. We go up to 9 milligrams, and I'm going to talk more about dosing in a moment. We have tablets that dissolve under the tongue. We have a topical cream, and then we have a formulation that I'm very proud of because it was my idea to bring this on, but it's because we saw a lot of people post-COVID showing up with eczema and psoriasis. I said, we have to do something about this. So we worked together to create this great formula that works really well and contains ivermectin, LDN, zinc, and hydrocortisone. It can also be made without this, which we would take the hydrocortisone out of it if you are applying it to a kiddo or if you are applying it long-term, because steroids do have a long-term, I shouldn't say long-term, they do have an effect on the integrity of the skin, and they will break down the barrier of the skin if used for long periods of time. So it's extremely safe, and you've probably used hydrocortisone cream before, but you don't want to use it every day for the rest of your life. And that is why. Here's before and after just of 1 week of using this particular cream. This was on a young lady's neck, and applying it twice daily just for 7 days. You can even see the area is much lightened up for her. Here is a scan in a patient with ulcerative colitis after using 6 months of low-dose naltrexone. You can see all of this gunk and inflammation here in the intestine, in the bowels. And here, this is, I'm not a gastroenterologist, but this is much, much clearer, cleaner, and healthier tissue that we're looking at on the right-hand side. All right, so what's the comparison? Naltrexone versus LDN. Remember, exactly the same ingredient. It's just a dosing conversation. Naltrexone is used for alcohol and drug dependence. LDN, that's your anti-inflammatory, autoimmune, dermatology, cancer drug. Typical dosing for naltrexone, up to 300 milligrams a day. LDN, most people live at 4.5 milligrams a day. I'm going to talk about the fact that LDN requires a titration, which means you work up slowly. There is an age limit for LDN, meaning that it is weight-based, and if anyone is over 18 pounds, they can use it, so that's pretty small. And then side effects, the most common ones with LDN are usually one of two things. Either GI discomfort, which is transient and will go away after a few doses typically, or vivid dreams. Now, since you can appreciate the mechanism of action of low-dose naltrexone and how it works to increase endorphin production, it makes the vivid dream side effect less scary. The reason that that happens is that we used to think, the way that we were taught, is that LDN is more effective if given at night. And the reason why is because endorphins are on high when you're sleeping and when you're dreaming. That's what makes your dreams vivid, is when you're having an upsurge of release of those endorphins. Because LDN further increases the release of endorphins, that's why it becomes vivid. If those vivid dreams are bad and you don't want them, then you can move the naltrexone to a morning dose. If you are pregnant or breastfeeding or planning to become pregnant, obviously you'll need to discuss with your physician, because LDN crosses the placenta, can affect baby, and also can be passed into breast milk. If the side effects are experienced, I like to try reducing the dose for 10 days before bumping it back up and re-challenging. And so what I mean by that is, this is a lengthy slide, but it's kind of an illustration of what we do. So most people would start out at a 1.5 milligram capsule of LDN and do that for 10 days. For the next 10 days, you take 2. For the next 10 days, you take 3. By the time that it's 30 days and you're ready for your refill, we can tie a bow on that month. And considering that you tolerate 4.5 milligrams well, we'll get a new prescription for your doctor, from your doctor, for 4.5 milligrams. And then you can just take 1 capsule once a day. It's less capsules for you, therefore you pay less for your prescription, and it's more money back in your pocket. It is important to note that you may get worse before you get better. LDN is also a mast cell stabilizer. So anytime that we make an attempt to stop something from getting shaken up and overreacting, it has a stabilization period. So it needs to find its happy place to be calm again. And so that's why sometimes people get worse before they get better. So what's the expectation on improvement and committing? Many people who start LDN are on LDN for the rest of their life. If we're talking about an autoimmune condition that is either genetic, or we have something that we need to address that we can't really get to the root cause of it because it is genetic or it's ingrained for whatever reason, or we've had some sort of a trauma that's causing the pain, then person may be on LDN forever. Either way, you need to be sure that when you fill that prescription the very first time, you're willing to commit to it for at least 6 months. I fully anticipate that you will experience many benefits from LDN far before 6 months. Usually after a few doses, days or weeks, the pain or inflammation is addressed, brain fog is expected to improve, and the immune system is expected to stabilize. However, if you're not where you want to be, especially within 6 months, we may need to up the dose, or we may need to say, all right, LDN isn't working at all. But it does require a titration, commitment, and this is not something that you take as needed, because you will backslide and you'll need to start over with that titration again. Okay, so I do have a couple of case studies here. The first one, I love these pictures. So this is someone who has chronic Epstein-Barr, and we suspected MCAS initially. So young lady with a history of joint pain and that Epstein-Barr virus, food reactions. She was relying on 50 milligrams of Benadryl for every time that she had a flare. We introduced Amlexanox 40 milligrams for her on a daily basis for her uncontrolled food allergies, where she wasn't tolerating foods that she once tolerated. So, with that, she experienced a lot of resolution in her joint pain, this butterfly rash that is on her face. It's very characteristic of autoimmunity and food allergy reactions. And I love this. At the time that I phone interviewed her, she had lost 40 pounds, and that was at roughly a rate of 1 pound per week. And what I like about that is sustainable weight loss. 5 pounds a week, 10 pounds a week is not sustainable weight loss, and you will rebound. This is something she can stick with. It lowered her blood glucose, her CRP, which is an indicator of inflammation in the body, and her hemoglobin A1C, which is a potential indicator of type 2 diabetes. What she said is Amlexanox completely cleared up my skin and gave me the confidence to get on a weight loss journey. And it wasn't just this. She made lifestyle changes. She went gluten-free. And so she did a lot of things synonymously, but it helped to reduce the inflammation and help her shed fat. You can see how just here in a little over a year, I mean, obviously she looks a ton happier. This rash is gone. She's able to introduce foods again. This is a rash that kept showing up on her side anytime she ate something that was high histamine. So she looks much, much better. I talked to her last week. She's now lost 96 pounds. All right, one of my more sensitive individuals is 60-year-old female with clinical history of asthma, food allergies, hypothyroidism, sex hormone dysregulation, swelling, poor digestion, fungal overgrowth, Lyme disease, Bartonella, Babesia, blood biofilms, POTS, which is postural orthostatic tachycardia syndrome. So going from laying down to up, heart starts racing, and MCAS. These two right here, we classically see with those people who have long COVID symptom. It's very, very typical presentation. I was talking about the super sensitive people. So she would have what we call a Herx reaction. A Herx reaction is a very bad reaction that most people have specifically to antibiotics. And the weird thing, though, about this is she was experiencing a Herx type reaction with non-antibiotic drugs. So most medications and most supplements that she took, she would get this. Usually I wouldn't make a slide so wordy and read the whole thing, but it's really quite shocking. Puffy eyes, swollen hands, intense redness in the ears resembling a sunburn, severe itching affecting the mouth, nose, face, torso, swollen tongue, darkened lips. Patient described a sensation in her calves as if they were about to pop, and a spongy feeling in her scalp. Remember how I told you a lot of times people say they feel like their brain is too big for their skull? She is one of these people. Pruritus, which is itching, headaches, and dry heaving. And that could be just from taking a simple supplement. So most things that would work for most people did not work for her. Any attempt at physical activity, lymphatic mobilization, so that would be like dry brushing or rebounding on a trampoline, would literally leave her bedridden for 1 to 2 days. She would be so dizzy, she would have to hold on to things and she would fall. At intervention, when I first spoke with this guest, I said, why don't we ask your doctor if he will prescribe you Amlexanox? So let me back up. When I first intervened with her, I said, I need to do a med rec, which is med reconciliation, and I need you to send me everything that you're taking. It's a full med list, it's a full supplement list. I see some long ones. The longer ones I usually see are around 40 to 50 different products. That's a lot. Hers was 81. And what I was trying to achieve with that was to lop some off wherever there was some therapeutic duplication, meaning maybe she was on 2 or 3 products that were doing the same thing, and over time she just didn't realize it. Not the case. I could not take one off of her list. So I said, why don't we add one more? Let's add Amlexanox and see what it does, because I think it's going to make a big difference for you. And I didn't tell her this on the front end, but I was anticipating she'd be able to come off a lot of the stuff that she was on. So at the time, she was fully dependent on oral antihistamines, inhaled steroids, and some days she would be on very high doses of these antihistamines just to get through daily activities. Her maintenance routine relied on low-dose naltrexone, 9 milligrams, nebulized albuterol, so puffing it in, the albuterol inhaler, which we consider to be a rescue inhaler, some PEMF therapy, IV ozone, blood irradiation, Myers cocktails, which are IVs, infusions. And again, she came to me with 81 medications and supplements in total. What I meant to mention is many patients will come to us on low dose naltrexone already and are very well controlled, but not fully. The way I describe Amlexanox is it can clean up the mess around what LDN cannot. So in January of last year, that's when we started Amlexanox for her, just 40 milligrams a day. By day 3, she only required the albuterol inhaler, not needing to nebulize anymore. Within 7 days, she reported marked reduction in airway mucus production. And after 2 months, she was having improved breathing, significantly reduced the symptoms of MCAS, eliminating her need for inhaled and nebulized albuterol. So no more rescue. This is what we call a reduction in polypharmacy. Polypharmacy just means a lot of drugs. So just 2 months in, following the addition of Amlexanox into her routine, she reduced her medication and supplementation regimen from 81 to 17 products. This was like a huge win. So much of a win that I created a case study for her and we wrote it up in the Journal of Independent Medicine, which is that IMA Health that used to be FLCCC. This is published this year in the inaugural edition of their independent medical journal, which means it does not support big pharma. It is not funded by anything that is trying to get a drug approved. We are simply reporting what we witnessed clinically. And so I was pleased to be able to write up her case in there and share this with a lot of people. If you didn't already know, on our website, we always have every quarter a newsletter that is written by myself for providers and for patients getting the same information, seeing the same information at the same time. We do have one on Amlexanox on there if you'd like to share it with a physician, if you're not a guest of the Hotze Health and Wellness Center, if you want to share it with a friend that needs to read that or hear that. These are all available on our website. And then on the Journal of Independent Medicine website, which is imahealth.org, you can get access to that journal article and all the other ones for free if you're interested in the first edition. All right, so in the chat, I put my contact information, but I really want to thank you for hanging out with me for just about an hour. I do have one more thing that I really need to bring to your attention before I let you go. And that is that if you have not heard this already, if you received our emails, then you do know that on August 6th, so last week, the FDA is proposing a ban on all desiccated thyroid medications. That is also your natural thyroid medications. So if you get our desiccated thyroid prescriptions, they are at risk. Additionally, if you are on Armour thyroid or NP thyroid, which are the manufactured commercially available drugs of desiccated thyroid, they are at risk. If you have your phone, please take it out now because I want you to scan both of these QR codes and I want you to sign both of the petitions because your medications are at risk. Why is this happening? The FDA is off their rocker. That is one reason why, but I'll explain the reason behind it. Desiccated thyroid products, which are derived from a pig's thyroid, which is how we can call it natural, is the desiccated thyroid active ingredient, which is called desiccated thyroid, comes from a pig's thyroid. It is a pig's thyroid that is extracted from the pig, dried, which is what desiccated means, and then it's created into a powder, it's tested, it's sent to the manufacturers of Armour thyroid and NP thyroid, it's sent to compounding pharmacies like Physicians Preference Pharmacy, and then we tailor that dose to you based on whatever you need. But it's the same active ingredient. The problem is that the FDA is now taking action on desiccated thyroid drugs that have been around for so long that before the FDA started requiring what's called an NDA or a new drug application, which is what someone submits to the FDA when they say, I want to bring a drug to market, desiccated thyroid prescriptions were already around. So they were grandfathered in as an approved medication. The FDA's claim is this is an unapproved medication. We have seen over the past many decades how well our patients do on desiccated thyroid. As a pharmacist, I can tell you that 80 to 90% of my patients do much better on desiccated thyroid than they do on T3 or T4 alone. Desiccated thyroid has the T3 component, which is your active part of your thyroid hormone, and it has T4, which is your inactive form. Their push is to get everyone in the next 12 months over to the synthetic version of thyroid, aka levothyroxine, which is T4, aka Synthroid, which is the brand name of levothyroxine, which is T4. The problem with this, and we see it all the time in our practice, is if people do not have the ability to break down T4, the inactive form, and convert it to the active form, then why are you even taking it? What controls your mood, your brain fog, your metabolism, your hormones is largely the active form. Where the FDA has gone wrong here is they have said, well, we want to categorize this into something that's called a biologic. Compounding pharmacies can't make biologics, only manufacturers can make biologics. But you have to apply for a biologics license, which takes several years. And to go through a new drug application, many drugs take a decade plus to bring to market, and they are going to ban this, they say, within 12 months. Where they've gone wrong on the biologic thing is their personal definition of a biologic is something that if it is pulled from an animal, making it something that's coming from biology, then it's the active ingredient that they're talking about. The active ingredients in this desiccated thyroid is T3 and T4, not thyroglobulin. And they're saying that thyroglobulin is the reason why it's an issue because desiccated thyroid contains thyroglobulin. It's greater than X amount of amino acids and all of these different requirements. Essentially, they've gone against their own definition, which is not a shocker, but is what we are up against. The last thing I'm going to say about this is not just a patient access issue, it is also a conflict of interest. The company that makes Armour Thyroid is called AbbVie. AbbVie is a biologics company that makes a very long list of biologic drugs. They are saying, well, someone should have to have a biologics license to make this, and if they don't, they can't make it, they need to go away. We're going to switch them over to synthetic thyroid. Guess who also makes synthetic thyroid? AbbVie. So they're not losing on anything if they can get people switched over to the cheaper drug, and many patients do not respond to that. So if you have not heard this PSA, please, please, please go to these two different petitions, sign them. This is how our information will get to Congress. Share your personal information. You do not have to say, share your personal story. You do not have to say you get it from Physicians Preference Pharmacy. In fact, please don't. Just say how important these desiccated drugs are to you. Unfortunately, we do have to rely a lot on physicians and patients and everyone all together pulling together to help fight against retaining access to our drugs. So I just wanted to let you know the update on that. That is all that I have, and I thank you guys so much for sticking with me. I know that I went a little bit over here, but there were definitely some things that I needed to talk about. So if you guys have any questions, I'm definitely more than happy to take them now. It looks like I have a couple in the chat, so you can post them specifically in the Q&A if you're able to do that. It says, first question, what is the mechanism of action of LDN and also naltrexone? What neurotransmitter receptors is it working on? So I think we covered that. A lot of different mechanisms of action. As far as the neurotransmitters and receptors, it's those enkephalins or the endorphins, and it's also working on the opioid receptors primarily. There are other receptors that, to a lesser extent, LDN does work on. What nutritional deficiencies does LDN cause? What increases of nutrients, macro, micro, does it need more of to work properly? That's a good question. To my knowledge, there are no drug-induced nutrient depletions or deficiencies that LDN leads to. And I think the way I'm interpreting this question is, do you need to take a certain amount of nutrients or types of nutrients to increase its absorption? And the answer to that is no. What about ERFA thyroid from Canada? What will companies like Armour Thyroid and Acela do? What are they all doing? Evil, just evil. Yes. So we covered that. I can see based on the timestamp here that was written before we went over what happened with desiccated thyroid. And then last question, is there any conflict to take either of these while also taking sirolimus? Good question. And I actually took something off my slides earlier today. Um, it depends. If you're taking it at a dose that is a weekly dose that we recommend. So if you're taking sirolimus or rapamycin, which is that medication I talked about that's taken just once a week, we take that to support cellular detoxification, to decrease inflammation, and to extend longevity. One of the contraindications of taking low dose naltrexone can be for people who are taking anti-rejection drugs. So those people that have had a organ transplant and then take anti-rejection drugs like sirolimus or rapamycin for life, but at high doses. So if the person also has received some sort of a transplant and is taking those high doses, there will be an interference. Taking something like rapamycin or sirolimus at a low dose on a once weekly basis is not contraindicated with low dose naltrexone. This is an excellent question. We have many, many guests who take those concurrently. And then is Amlexanox something that will need to be taken indefinitely? I didn't catch that. No, it does not. So, like I said, some of the main reasons that we use this are to address inflammation, autoimmunity, and things like mast cell activation syndrome. Using the example of mast cell activation syndrome, for example, that is a really tricky one. It is one of the trickiest conditions to address. And if I could sum up a major topic into a couple of sentences, usually we catch it in late adulthood, and almost exclusively it stems from a childhood trauma. So even though there has been a lot happening in between then, you can't just unwind the physiological issues. You also have to unwind the childhood trauma. And many times people don't go that far to unwind it. So they may be reliant on Amlexanox for life. Other times, we're just trying to calm down the immune system. Maybe we're trying to support metabolic health. And so once we get down to our baseline, we should be able to stop that. If you had gut issues, what is the best way? If you have gut issues, what is the best way to take both of these? So both the Amlexanox and the low dose naltrexone. My first question would be, what gut issues are we talking about? And also, is it autoimmune related or not? If it's autoimmune related, I would start with the low dose naltrexone. And actually, I'd probably start with it anyway because it requires a titration, meaning we have to work up, starting low and working up slowly. So as you begin to introduce the LDN, you're not even going to get to your target dose at the fastest would be within a month. So if you got started on that, did it for a couple weeks, maybe a month, and then introduce the Amlexanox, you would really be addressing most of the issues, if not all, that are involved in the gut issues. But again, this is of course just a general question, but my first question would be, what type of gut issues are we talking about? And then last question I see is, can I rewatch this? Yes. So you guys will be getting a replay of this along with the slides, so you can refer back to what I have written and also what I have said. As far as pricing, I just wanted to go over that really quickly. Is for the 40 milligram capsule, if we're looking at just 30 capsules of that, it costs $59. And also, if you're going for 90 capsules, it costs $129. Okay, so a new question here. This is a follow-up question about the gut issues. I mean cream or nasal. I have Hashimoto's. So if we're talking about I'm not sure I completely understand that question. Low dose naltrexone can be applied topically, but we only do that in children or if we're trying to address something on the skin. Otherwise, we take it orally. So the oral route of administration is preferred. Okay, well, I thank you guys for sticking around with me even a little bit longer, and I'm sure questions will come up. So any questions that you do have, please shoot me a note, call the pharmacy, and I cannot wait to see you next time for our next topic. You guys take care. Talk to you soon. Bye-bye.